Welcome back to Data Talks Live. I'm Dr. Tom. On this show, we dig deep into the numbers, peel back the spin, and try to find the data-driven truth behind the issues that matter. Today's episode tackles three fascinating stories that at first glance seem very different, but all connect to one overarching idea: how our health, our knowledge, and our systems are evolving, and what that means for all of us. Here's what we'll cover today. Segment 1. What life expectancy looked like in the 1880s, and what modern medicine, beyond the basics, has contributed to extending life. Segment 2. A question of who's really benefited from early gains in life expectancy and how much modern medicine has added to the top. And Segment 3. A major national effort to unify Alzheimer's research data, why this matters for the future of medicine and for you and society. Let's dive in. Imagine being born in the 1880s. Your life might seem full of mystery now, but in your time, the average U.S. life expectancy at birth was roughly 40 to 45 years. That's right, ish years. And yet many adults who survived childhood lived significantly longer. What does that tell us about morality, childhood risk, and what modern medicine really changed? Here's the context. In the United States, when your great-grandparents were born in the 1880s, the average life expectancy at birth was around 40 years. About 39 for men and 41 for women. By 1900, it had risen to about 87 years overall. This historic low number was heavily skewed by high rates of infant and childhood mortality, maternal mortality, poor sanitation, lack of antibiotics and vaccines, limited medical care, and unsafe water. But here's the important nuance. For people who survived infancy and childhood, the realistic expected lifespan was much longer, often into their 60s and 70s. The average at birth, while useful, masks the high early death risk. So when we say life expectancy was 40, we need to be clear. That's averaging in babies, young children, and many who died of infectious disease early, maternal deaths, and workplace hazards. What does that mean for today? Today in the U.S., life expectancy at birth is about 78.4 years. For males, about 75.8 years, and for females, about 81.1 years. So over roughly 140 years, the average at-birth life expectancy has roughly nearly doubled, from 40 to 78. That seems like a tremendous gain. But if we dig deeper, what part of that gain is due to infant and child mortality reduction and basic public health improvements, such as sanitation, vaccines, and clean water, versus what part is due to advanced modern medicine, ICUs, organ transplants, cancer therapy, and heart disease care? We'll explore that next. The real question: how much of that gain from 40 to 78 years is due to high-tech medicine, beyond infant mortality, vaccines, and basic hygiene? And what percentage was thanks to older, broader public health improvements? So you're living to 78 years on average now. But ask yourself, how much of that extension over the 1880s baseline is thanks to modern medicine? The high-tech cures, the medical machines, the surgical interventions, versus the more basic but foundational public health advances. Well, I've done the rough math, and here's an updated unpacking. So we've had an increase from 40 years to 78.4 years, or an increase of 38.4 years, which is nearly 95 to 100%. But most of that increase occurred because of reductions in early life deaths, infant mortality, childhood infectious disease, maternal health, unsafe water and food, and sanitation. If you survived childhood, then your expected lifespan was already much higher than 40. Several studies suggest that incremental gain for adults surviving childhood is more modest. For example, if someone reached the age of 20 in the 19th century, they might expect to live into their 60s or even early 70s. Today, if you reach the age of 20, you might expect to live into your early 80s. So the extra adult years added by modern medicine beyond the basics may be on the order of about 15 to 20 years, not 40. For instance, one research summary estimated that reduced infant and childhood mortality accounted for 40 to 50% of lifespan gain. Infectious disease control, such as vaccines and antibiotics, accounted for 25 to 30%. Chronic disease management and modern hospital and ICU care accounted for 15 to 20%, and other late life interventions accounted for 5 to 10%. Putting that in percentages, if modern clinical medicine beyond sanitation and antibiotics accounted for 15 to 20% of the total gain, that means of the 38 years gained since 1880, maybe 6 to 8 years are due to late life high-tech medicine, and the rest, 30 plus years, are due to basic improvements. If we look at survivors of childhood only, the proportion may shift a little, but the main point remains. The biggest leap in lifespan came from public health, not from fancy medicine. In other words, if you ignore infant mortality, vaccines, and hygiene, then modern medicine contributes maybe 10 to 15 years of extra adult life, which is still meaningful, but less than the raw doubling of lifespan might make you think. This has big implications. We often valorize high-tech medicine, new drugs, gene therapy, ICU machines, and they are vitally important. But if we forget that the largest gains in survival came from frictionless public health changes, such as clean water, sanitation, immunization, and safer workplaces, we risk misallocating resources, and it raises the question, what should we expect going forward? If modern medicine has already picked the low-hanging fruit, are future gains going to be smaller? In fact, recent evidence says yes, life expectancy gains are slower. So if you're thinking about your health strategy or public policy, consider where the biggest gains are likely, not just in expensive hospital care, but in prevention, environment, early childhood health, social determinants. The returns might be bigger there. Now let's shift from lifespan numbers to how the research ecosystem is organizing itself for future gains, especially for massive challenge, Alzheimer's disease. Our final segment covers a major national effort to unify Alzheimer's research data. What if the next big leap in lifespan and health span doesn't come from a single drug, but from harnessing data at a massive scale? Combining research across institutions to crack one of the hardest diseases of our time. And that's exactly what's happening now. Here's the story. A national effort, valued at $2.7 million, has been launched to unify Alzheimer's research data across institutions. The aim? To build a large interoperable dataset that span imaging, biomarkers, genomics, cognitive data, longitudinal tracking, so that researchers can identify patterns, validate interventions faster, and move from silos to scales. Why this matters? Alzheimer's disease and related dementias already affect an estimated 6.5 million Americans aged 65 and older in 2022, and projections suggest much higher numbers ahead. Treatment advances have been slow. Part of the reason is that the disease is complex, heterogeneous, and the data are fragmented. Many small studies, different protocols. By unifying research data, we move toward big science for Alzheimer's, the way we do for other large diseases, giving us the power to discover subtler signals, stratify populations, and test innovations more smartly. For example, a recent cross-sectional study found that the economic burden of Alzheimer's and related dementias alone in the U.S. was $344 billion in 2020 and projected to rise to over $3 trillion by 2060. That means, in addition to human suffering, the cost to society is enormous. So accelerating research has a huge payoff. By creating unified datasets, the hope is faster discovery of biomarkers, earlier detection, better preventative strategies, more efficient clinical trials, and ultimately, longer, healthier lives for older adults. This is a clear illustration of how data infrastructure, not just medical infrastructure, will matter for the next stage of life extension and quality of life improvement. Just as sanitation and vaccines drove the first leap, now large-scale data and systems may enable the next wave: chronic diseases, neurodegeneration, and aging itself. Linking back, just like in segment 2 where I said easy wins of life extension may be behind us and future gains are smaller, this Alzheimer's data initiative suggests the frontier is moving towards complex systems, aging brain, lifestyle, late-life disease, rather than simple fixes. And it underscores that the biggest gains may come from prevention, data, and early detection, and the system-scale coordination rather than one surgical breakthrough. So today we traced a meaningful arc from the 1880s life expectancy baseline to our modern 78-year average, from the recognition that the biggest gains came from public health rather than high-tech medicine, and finally, to how data, unifying research efforts for Alzheimer's and beyond, may drive the next leap. So 3 big takeaways. Don't misrepresent life expectancy at birth as the lifespan of an adult survivor. Context matters. The largest single leap in survival came from sanitation, vaccination, infant and child mortality reduction. Modern clinical medicine added meaningful years, but fewer than the headline doubling suggests. If we're to continue extending healthy lives, the next frontier isn't just better surgery. It's data systems, prevention, early detection, chronic disease management, and aging research. If you enjoyed this episode of Data Talks Live, please subscribe, share it, and drop us a review. I'm Dr. Tom. Thanks for listening or watching. Stay curious, stay skeptical, and speak data.